So we'll move on. Obstetric conundrums. I'm going to be doing a little bit of talking, but I want to welcome my colleague, Dr. Anne Armstrong, who's a consultant obstetrician and gynecologist and who works with me every Friday morning at Simpson Centre for Reproductive Health. She's a consultant also at St John's Hospital, which is where she is this morning, and I'm at the Royal Infirmary of Edinburgh. So because we can do things virtually, it's nice we're going to join up. And Anne has a particular interest in obstetric haematology, but very much in the management of thrombotic conditions in pregnancy. And as I said, she's going to present a case alongside myself. So I'm going to start off and get started. We're going to present two cases. Joe, if we could have the first slide, please. So we've got no disclosures. This is a picture of Dr. Simpson, who was the person that basically our unit's named after. Next slide. He left a huge legacy in Edinburgh. These slides show statues in Princes Street for James Young Simpson. He discovered chloroform anaesthesia and was instrumental in reducing the pain of childbirth. And there have been various Simpsons hospitals shown in the slides here in Edinburgh, but around about 2005, 2006, the Simpsons Centre, which had been separate to the Royal Infirmary in the centre of the city, moved out to the Little France site along with the rest of the Royal Infirmary, but it remains a unique part of the Royal Infirmary in terms of how you get to it, and it's got its own unique identity. Next slide, Joe, please. And we have a wide multidisciplinary team. This is a pre-pandemic team, which seems very large, and we're not all wearing scrubs and masks. But as you can see, on a Friday, we have access to all sorts of people that might help women who are pregnant or who have recently delivered babies and who have had clotting problems. So we have a thrombosis nurse, we have a midwife, we have obstetric anesthetic team doing a clinic just down the corridor, and our colleagues from obstetrics. Two particular obstetricians have an interest in hemostasis, thrombosis and haematology, and administrative and clerical support. So a wide multidisciplinary team. And the cases that you'll hear about today require many members of the team on each occasion. Next slide. So we're going to highlight two very recent patient cases, just to try and discuss some first principles of management, some of the pitfalls and conundrums, and just to let you know that both patients have given full consent for their histories to be presented today. Next slide. So I'm going to present the first case, 37-year-old lady, sort of primigravida, and she has Marfan's syndrome. She is on warfarin. Usually her target INR is 2.5 with a range of 2 to 3. The reason why she's on warfarin is that she has, due to the Marfan syndrome, had aortic root dilatation and mitral valve prolapse. And she required an aortic root replacement in 2015 at the Freeman Hospital in Newcastle. And alongside that, she required the insertion of a mechanical aortic valve, a carbomedics valve, and she also had a mitral valve repair. She was found on MRI in 2017 to have a borderline ejection fraction of 50% and mild residual left ventricular dilatation. So quite a complex cardiology history. Next slide. She actually attended for pre-pregnancy counselling. Myself, an obstetrician with an interest in cardiac issues in pregnancy, an obstetric anaesthetist, thrombosis nurse, and I've missed out a cardiologist, we're also there. And we all met with the couple and discussed the ins and outs of pregnancy itself, the changing of anticoagulation, the teratogenicity of warfarin, particularly in the first trimester, the choices of anticoagulation in the different trimesters of pregnancy, and the risk of embolism from the valve and of valve thrombosis. And it would be too long in this talk to go through all of that. She was keen to proceed, and she personally chose to switch preconceptually to therapeutic low molecular weight heparin, which we advised would be given twice daily dosing with low molecular weight heparin levels. And we took our peak levels from the European Society of Cardiology guidelines. Next slide, please. But what I didn't know at that time was that she needed assisted conception. She needed fertility treatment. And that became apparent that she not only needed IVF, but she required pre-implantation genetic testing. And that was going to that caused a number of challenges. First of all, she needed re-counseled about the risks of valve thrombosis, embolism, and hemorrhage associated with the egg retrieval. Egg retrieval was planned for September last year, and you'll all remember that we were in the throes of post-lockdown and extraordinary pressures really on the NHS. At that time, we had a number of staff shortages in our laboratory, also within the thrombosis team, particularly with our nurse-led service. And I think you will probably also remember that there was a shortage of clotting tubes. And it became quite logistically difficult to actually take this on, but we did take it on. And because it was a complex case, we wanted to try and make sure that any dates for planned operations were considered very carefully by the multidisciplinary team due to staff shortages and public holidays. Next slide, please. How did we approach the challenge? Egg retrieval requires a general anaesthetic. We've already involved our anaesthetic colleagues, but it involved a different anaesthetic team. Puncture of the ovary itself to get the eggs can lead to hemiperitoneum of up to 1 litre, I'm told, by our fertility colleagues. And so in a patient who's coming off and shortly going back onto anticoagulation, that was a potential hazard that we had to counsel the patient about. And we also had to counsel the patient about the risk of valve thrombosis and embolism as we were taking the patient on and off and restarting anticoagulation. Always wanting the minimum time on the low molecular weight heparin and maximum time on warfarin. Next slide, Jo. How do we approach it? I advised that we have an inpatient stay in the gynecology ward around the time of the egg harvest. We asked for some imaging, or our fertility colleagues put in place imaging post-procedure to ensure there had been no bleeding from the ovary after the egg retrieval. But the main challenge, and I'm sure anyone who does a lot of perioperative anticoagulation can vouch for, is that you need a date to basically base your management plan. And in this situation, the date of the procedure is not fixed because it depends on the ovarian reserve and the ripening of the eggs with hormonal stimulation. So we were working towards an approximate date, but we didn't know if it would be earlier or later, and we had to factor that in to when we stopped the warfarin and started low molecular weight heparin. There was also a 3-month delay or thereabouts for pre-implantation genetics, and that meant that we wanted to place the patient back on warfarin after the egg retrieval. So in between the various stages of IVF, it involves taking them on and off anticoagulation quite frequently. Next slide, please. So we did a very bespoke preoperative bridging plan. This lady has normal renal function and a normal blood count and is otherwise very, very good health. What we do in Lothian is we stop warfarin on day -6. As mentioned, we gave ourselves a little bit of a window of opportunity to get the patient worked up. What we did was took the patient's target INR, and we started weight-based dalteparin 12-hourly. And having worked with 12-hourly dalteparin, and I mean, obviously I know everyone uses different brands of low molecular weight heparin, the issue is we want to get this lady into the peak levels very quickly. And what we also want to do is give a stop time for the dalteparin pre-procedure. Next slide, please. Next slide, Jo. Thank you. So what we were doing was, I just wanted to sort of use as a learning point this escalation of dalteparin in the lead up to a procedure where we're actually stopping anticoagulation because we're trying to get her on the right dose. And there's this dose finding period. So we had her on different dosing regimens of dalteparin every 3 doses. And as you can see from the slide, the peak low molecular heparin level starts off quite low. And even on 10,000 units twice daily, wasn't really reaching the desired peak and came at about 0.74 units per mil, which probably is not high enough for this particular situation. Next slide, please. The patient went on to have her egg retrieval. There was a successful harvest of 9 eggs. Imaging several hours after the harvest showed no hematoma at the puncture site. And while she was on the ward over a 2-day period, there was no further bleeding. We gave a prophylactic dose of dalteparin post-procedure. I think it was the next day that we started her back on therapeutic dalteparin and worked things up, additionally restarting her warfarin. Next slide, please. The next thing that we learned was some months later that the pre-implantation genetics and in fact the IVF confirmed there was only 1 embryo to return. So from these 9 eggs, there was a number of embryos and then there was only 1 left to return. The multidisciplinary team discussed the potential date for embryo transfer. Now at this point, we've got a bit of an idea of how she's handled her low molecular weight heparin. But interestingly, the UCOS survey from 2017 suggests a higher starting dose due to the high rate of a mechanical valve thrombosis during periods of transition. So in their survey, they found that the rates of thrombosis for valvular thrombosis was at this kind of transition period and also during labour, as you're stopping and starting anticoagulation. So you'll see the starting dose for dalteparin is not 200 units per kilogram per day, which is what we use for venous thromboembolism. But it's 250 units per kilogram per day, which you would split usually into a 12-hourly regime. So we'd already been doing that, having that dose 10,000 BD, and we knew it really wasn't reaching the mark. So what we did was we had no idea again when this embryo transfer would happen. We had a rough guide. We started the transition from warfarin to low molecular heparin 3 weeks ahead of the likely embryo transfer date. And we switched the patient from warfarin to low molecular weight heparin. And we did trough and peak monitoring. And this was the hope that post-embryo transfer she would become pregnant. Next slide, please. So as I mentioned, we started her on dalteparin 10,000 units twice daily. We increased the dates. My table's not quite come out properly, but my table there is supposed to show the increasing. No, sorry, it shows you 12,500 unit twice daily dosing peaks and troughs. And you can see they vary a bit. We basically had to do a number of switches. So this involves the patient coming up and down to our unit. We use the thrombosis unit at the Royal Infirmary to do the testing with our anticoagulant nurse. So she doesn't go to the obstetric unit or the fertility unit to get the levels done. She's done in the anticoagulant, but the levels are done by the anticoagulant team. And we had to increment her low molecular heparin to 12,500 units twice daily to even start to try and get her into the correct peak levels. Interesting to look at the trough levels. We're not sure what trough levels mean and whether and what level to aim for really, but you can see that they're between 0.36 and 0.4 on this particular regime that we used. Next slide, please. So our ET date, the embryo transfer date, was the 9th of March. This involves a hysteroscopy, so there's very minimal bleeding risk. It's not like the egg retrieval. No sedation or anesthetics required, so it's a lot simpler. And our fertility colleagues felt she could just go into the procedure fully anticoagulated. But I felt what we should do is withhold her morning dose of dalteparin because she is quite highly anticoagulated as they place the scope into the uterus to place the embryo on the endometrium. And what our gynecologist did was used his judgment about restarting a dalteparin post-procedure. It was an uneventful procedure. Next slide, Joe, please. And 2 weeks later, the patient takes a pregnancy test, but sadly that was negative. So the patient was restarted on her usual dose of warfarin, continued on this high dose of dalteparin until her INR was greater than 2. And she's well and is now actually quite keen to rediscuss a possible further round of IVF. Next slide, please, Jo. So I think the learning points here is mechanical heart valves in pregnancy is a very small group of patients, but they're patients with incredibly high risk. And particularly patients undergoing assisted conception. This was my first N of 1 experience. It provides a lot of challenges. We know from the UCOS 2017 survey that valve thrombosis occurs not just at the time of labour when you have to withdraw anticoagulation, but it seems to occur in the first trimester as clinicians are transitioning from warfarin to the heparin regimen. And it's because of this trying to get them in range. And my recommendation is absolutely to use this higher starting dose, because you'll see from this case that we had to go higher. We're not at all clear of the target peak levels to attain. There are a number of different guidelines stating different peak levels, but BD, twice daily dosing, is definitely recommended. 3 times daily dosing, not widely accepted. So the role of trough levels is unclear. And just to let the audience know, the British Society of Haematology, under the chairmanship of Will Lester, has produced guidance that is now at the level of stakeholder review and should be published later this year. And it does have a small section on assisted conception. So we're going to move on now to my colleague, Anne Armstrong. Next slide, please, Jo. I'm going to hand over to Anne to talk about another case with some conundrums.
Thank you, Julia. So obviously that was a very complex case. Hopefully this will be a little bit more straightforward, but does raise some questions and challenges that we see not infrequently in obstetrics. So this is a 30-year-old first-time mum who is slim, fit and healthy, a non-smoker, a natural conception with a singleton pregnancy, who works quite long hours in the legal profession, and actually a lot of that is desk work, particularly being in COVID. And essentially she had a very straightforward antenatal course until 30 weeks gestation, where she presented to our obstetric triage with this intense pain in her left calf and pain moving up to her thigh. Her father, if you spoke to her in his late 50s, had a relatively unprovoked DVT, and several years later went on to have a PE. And when you spoke to her, she said over the last week, her leg just became more achy, and her thigh, she described to me, felt very full and tight. Next slide, please, Jo. So Doppler ultrasound scan revealed quite an extensive thrombosis of her upper leg. When we looked scanning wise, the common femoral vein seemed to be patent, and obviously with a gravid uterus, it's quite difficult to image, but the iliac veins also examined as best as possible appear to be patent. So she was admitted to our antenatal ward and fully anticoagulated with a twice daily regimen of 6,000 international units. All a bit of a curveball for her. She had normal renal function, normal hemoglobin. At present, we don't routinely give women iron. We're working towards that. Slightly low hematocrit. And she was started on some oral iron supplementation. And we saw her as a team on the ward. She was coping with her injections, getting her head around the diagnosis, having really never been in hospital before, and was keen to discuss possibly moving to a once daily regimen. And we reweighed her, and she was 70 kilos, and actually switched her to a once daily regimen of 15,000 units. She was very keen to go home, and actually pain relief wise, she didn't have much pain. I think she was probably sorer than she was admitting, but we gave her some decent oral analgesia with a supply for home, but she was very keen to go home, and we made plans to see her the following week. Next slide, Jo, please. So as I said, she was discharged, obviously having had a long chat about why we need to treat, a bit of a touch on our 24-hour rule with respect to regional analgesia, with planned follow-up in our haematology clinic. She was referred to our anaesthetic team regarding the 24-hour rule with respect to citing regional analgesia, and was a prim, so first-time mum. She was seen the following Friday, so a week later, where she walked into clinic with significant improvement of her symptoms and was really self-administering her low molecular weight heparin injections really well. She was seen 4 weeks later with complete resolution of all pain and swelling, and she was not fitted with stockings, and we plan to review her at the end of the 39th week to discuss induction, mode of delivery, and have some clinical oversight of that. So what actually did happen? So she essentially, sorry, next slide, Jo. So sorry, what's our approach to anticoagulation in labour? So it very much depends on first-time mums, second-time mums. And I think it's very much an individualised approach that we have. We very much encourage women to aim for vaginal births, particularly first-time mums. And I think setting up that rapport with a small team is really helpful for these women. There's a lot of false advice, worries about being fully anticoagulated. Well, I have lots of bleeding at delivery. Do I need a cesarean section? And essentially, we encourage women to aim for vaginal birth, knowing that almost 30% of first-time mums require induction of labour for purely being post-dates. So we see no benefit in bringing women in to try and get them into labour before they're ready. And we individualise things by looking at a balloon catheter induction in the post-dates period, no later than about term +7. And otherwise, clear advice if they think they're in labour that they come in and are assessed. Obviously, they contact our obstetric triage where they're invited up to ensure they are in labour, having omitted anticoagulation and having clinical oversight. Are you in labour, are you not? Points of view to points of contact for review if they are not in labour. Obviously, if women come in labour, we will cite IV cannula, take routine bloods, so full blood count, coag, group and save, and inform all the relevant teams. Clearly omit low molecular weight heparin until delivery, and we advise active management of the third stage with IV access and restarting of thromboprophylaxis doses, usually no later than 6 hours after delivery, irrespective of the mode of delivery, as long as we have no ongoing concerns with bleeding. So for this lady, what did actually happen? So she actually presented a couple of days before we were seeing her in the very early stages of labour and was seen at about 7 o'clock in the morning, had a vaginal examination, tightening about 1 in 10 with a fingertip open cervix, so quite early doors and a first-time mum. She was reviewed by one of our registrars and we suggested she come into our hospital for observation, but she's very keen to go home to try and establish at home, and very sensible, didn't live far away and was keen to establish. About 14 hours later, she phoned back our triage, having omitted her low molecular weight heparin, and she had ruptured her membranes, initially clear, and they turned to green. So we now had meconium stained liquor, and she was invited up to hospital, where she attended just after 7 p.m, Muse of 0, contracting about 3 in 10, requesting some oral analgesia. We had IV cannula and blood sent to the lab, and we were waiting for a room up in our busy labour ward. And then suddenly, just before 8 o'clock, there was a bradycardia noted on the CTG. And when the midwife looked between her legs, there was a vertex visible. So she then was very quickly, because there was a room available in our low risk birth centre, which is literally opposite our obstetric triage, she was quickly wheeled through there, and less than 10 minutes after transfer had a normal vaginal delivery. Jo, next slide, please. So as I said, she had a spontaneous vaginal delivery just before term. And when Dr. Anderson, my colleague, was asked to review her, her team was asked to review her the next day, Dr. Anderson had no idea where the birth centre was and had to ask for directions. It's our midwifery unit, low risk care. And when Dr. Anderson was asked to see, the patient was very, very keen to go home. And we just had to kind of say, you know, we need to re-escalate things. She had active management of the third stage, estimated blood loss of 400 mils, with a small second-degree tear, which was sutured under local anaesthetic. There was no concern with bruising, bleeding. Her locale was normal. And we kind of had to convince her to stay in hospital. So she was admitted to our postnatal ward and clear advice on re-escalation plan. She remained overnight for another night, but was absolutely desperate to go home. We supplied all of her re-escalation low molecular weight heparin, and she already had her 15,000 units at home and was fully aware of points of contact if she had any concern with bleeding. We were aware placenta was complete. There were no concerns with membranes being ragged. So we felt it was appropriate that she could go home, and she went home at lunchtime on day 2 following delivery. Next slide, please, Jo. We're planning to see her tomorrow in our clinic for a consultation. She's been started on the progesterone-only pill, and we will see her to advise on anticoagulation. She's breastfeeding at the moment and already is on the progesterone-only pill. And the team will then review her in the general thrombosis clinic to decide on the optimum duration of anticoagulation. And certainly more extensive clots, we will consider anticoagulation up to 6 months, a minimum of 3 months complete treatment. And certainly with that really kind of pro-thrombotic time postnatally, obviously consider anticoagulation for that 3 months postnatally. And again, a bit of positive evidence about the duration from the point of view of post-thrombotic leg syndrome, but certainly a discussion about potentially treating for a bit longer, certainly the common femorals and iliac thrombosis, to try and reduce long-term problems with the leg. Next slide, please. So for me, sort of learning points from anticoagulation, I think historically, we have always given a twice daily regimen, and our COG would suggest that we use dalteparin as our low molecular weight heparin of choice, but we're certainly moving more towards once daily regimens, and certainly our patients are much happier in self-administering this for obvious reasons. We step away from doing levels, and I know our COG would suggest doing levels if you're out with the 50 to 90 kilograms. This lady was nicely within that, but actually a lot of our women are not of a healthy body mass index. But actually educating women on what the clinical response is going to be. Big clots are very, very sore, and I think we under-analgese these women. We don't set out that realistic expectation for the time frame. And for us, monitoring of the clinical response is the most important thing. There's obviously a really important need to have that team sort of overview of things and regular obstetric reviews in the lead up to term. Women worry about mode of delivery and bleeding at the time of delivery, and we always involve those conversations when we see women. We avoid the unfavourable induction of labour, which can take time. We used to use hormone pessaries where women would take 2-3 days at least to get to a point where we can perform an amniotomy. Actually, our Cook's balloon is much more favourable, with about over 90% of women being at a point where we can perform an amniotomy within 24 hours of having had that inserted. And I think it's really important when these women are being induced, as Embrace would say as well, to have this prioritisation to avoid prolonged periods off their anticoagulation. It's also really important, and again coming from Embrace, re-escalation of anticoagulation with an individualised plan, taking into account events at the time of delivery. But equally getting back up to therapeutic levels within the first few days. If you've had a straightforward vaginal birth, maybe we should be more proactive. Could they be fully anticoagulated by day 4, day 5? If cesarean section, day 6, day 7, again, be interested to hear what you think. And certainly we're currently doing an audit to try and assess what our process is. And we now write individualised care plans for re-escalation in our notes so that women can get re-escalated prior to us seeing women face to face. We're very accessible on phones to advise on anticoagulation, but again, taking into account what's happened at delivery and increasing awareness of full anticoagulation in the postnatal period with clear points of contact if women have any concerns of bleeding postnatally.